talking about provider onboarding today, discussing a bit about how you bring on a new provider, how you make sure that they're productive from day one. So let's talk a little bit about how this process works. So here you've got the doctor, and in most cases, when you bring in a new doctor, that image on the right of the dollar signs doesn't really exist for a while. This presentation has been communicated to many hospital CFOs and practice owners for years. I've been doing this for an awful long time and presenting this exact presentation in order to help them understand what they can be doing differently to ensure that when they do bring a new provider on board, they're going to be making money from day one. 99% of practices, hospitals, health systems, anybody out there lose money on a provider once they hire them. And it takes time for that cash flow to build up and for that practitioner to then end up producing cash, positive cash flow, so they are not a cost center. So with that said, some hospitals lose more than $7 million a year due to the lack of organized onboarding programs. Many practices have the same issue. Now, we do an awful lot of credentialing, contracting, and provider enrollment for our clients all over the country. We see this every single day. So for instance, right now, I've got a chiropractor that contracted with us to do the credentialing for a new provider that he's bringing on board. That provider's already started. We had an agreement signed with the client, the chiropractic practice, for over 3 weeks now, and yet we still don't have one piece of information on the new provider that has already started. So they aren't going to collect a dime off of any work that provider does until we're able to get started and get them enrolled, credentialed, and contracted with the commercial payer. Practices are more vulnerable than hospitals because they don't have a lot of money to fall back on or cash flow, and you can't hide these kinds of losses in a medical practice. So let's explain a little bit. So when you bring on a doctor, they usually have some kind of an employment agreement, and in that employment agreement, it dictates the day they start, and that employment agreement usually states that they're going to get paid some sort of salary or wage from the day they start. So right then and there, you're expending money in order to employ that physician, let alone the malpractice policy that you had to pay for, maybe some other things that you had to pay for. Maybe you brought on an additional MA or some additional staff in order to help support that practitioner. Well, these are all expenses that are being, they're outgoing expenses out of the practice, whereby the practitioner isn't creating any revenue coming in. So they're in a shortfall situation, meaning that they're immediately creating a loss for the practice. That is money straight out of the owner's pockets, or if it's a health system, it's coming out of the board of directors' funds in order to run the hospital or the health system. If it's a large practice, then that money is being anteed up and pulled out of the wallets of all the owners. Normally, in most cases, it's an equal share of that loss that the owners are anteing up in order to pay for that provider while they are not creating any revenue. So let's discuss the leaking sieve and why it occurs in almost every healthcare operation. And who makes the decisions to hire a provider? Is provider enrollment a stepchild to the organization, or should I say credentialing, as most people call it? We're going to discover some of that today. So, in most cases, most organizations are a leaking sieve, and meaning that there is money that is just dropping out of the bottom of the organization and nobody knows where it's going. In most cases, most people, most organizations don't even know how much money that practitioner has lost until somebody is requested to investigate that, figure out how much money we spent on this practitioner and how much money has been collected.